back to my channel. I'm Neurologist Nurse Muriel. To my new subbies, hey, how y'all doing? Thank you for hitting that subscribe button. To my oldies but goodies, welcome back. So y'all, I am heading to go get my braiding hair. I'm getting my hair braided today. I did come on live last night, but I'm going to start putting in the community tab when I'm going to do a live. I did mention it in my last video, but if everybody doesn't watch the video or gets to the video late, then you won't know. So my plan is to go live every Friday night at 9 p.m. 9 p.m. every Friday night at 9 p.m. If anybody has any questions related to anything nursing, nursing school, being a nursing student. Now I want to kind of give you the differences between acute care and long-term care, only because I do feel qualified to tell you some of the differences, being that I've worked in both settings. Even though my preference is one over the other, I'm not going to be biased. I'm going to try not to be biased when I tell you. And if y'all have any input on it, just like leave it in the comments below. First, I will say long-term care / rehab is a facility that holds, I used to say elderly, and they are not only elderly anymore. I've had a long-term care patient as young as 24 years old who was involved in a in a motorcycle accident, and his family wasn't able to take care of him at home, so he was placed in a long-term care facility. I've had people in long-term care facilities who were in their 40s who developed a debilitating illness. They weren't able to attend to their ADLs, and they didn't have anyone at home to take care of them. They thought they were going to come as rehab, because a lot of the patients come in, they come through rehab. A lot come through rehab. Some come directly as long-term care patients, but a lot of them come through rehab, and they, with the hopes of potentially going home, and then they're in such a shape to where they're not able to go home. So it's not geriatric anymore. It's all ages, and it hasn't been geriatric for a while. It's been all ages. So in long-term care, things can be different depending on which one you work at and their rules and regulations. But like I said, long-term care, most of them have a rehab floor where patients come in. They're getting rehab such as maybe PT, which deals with the physical mobility, things of that nature. OT, which is occupational, which deals with daily activity, things such as eating, combing your hair, drinking, things of that nature, trying to help you with OT. And then speech, what deals with things such as dysphagia, aphasia, swallowing, things of that nature, talking, things of that nature. And sometimes they, the patient or the resident requires adaptive equipment to help them with those things. So say someone has a trembling hand, they may give them, and this is something that OT would probably work with. Say someone's hand trembles and so they're not able to hold a fork or a spoon because their hand trembles when they're trying to feed themselves. So OT will work with them trying to feed themselves, but ST, which is speech therapy, may give them a weighted spoon. It's a spoon that's heavy to help steady their hand. So when they're holding it, they're able to pick up the food and feed it to themselves. So they all kind of OT, ST, PT work hand in hand. And that way, and there are some patients who come there specifically for that. Say it's post some type of injury, or, post some type of medical condition, or post some type of injury, say maybe a motor vehicle accident or a fall or something like that. Or it could be something neurological, something going on with them that's causing this, but they'll work with therapy for that. And if they're able to go home, then they go home. Everybody that comes through the nursing home doesn't stay. If they get their allotted days with therapy due to, whatever their insurance pays for, mind you, the long-term care facility is going to try to milk them for every last day that the insurance will pay for. They're going to try to get every last day out of them, because that's how PT, OT, and ST gets paid. But some of them are able to go home. Then some of them who conditions are just deemed to the point where they cannot go home, because even if we get them home health to come in and help the family for a few hours, there is no one home to take care of them after that. Some of them end up staying long-term. And in long-term care, the nurses there provide the medication under the direction, not immediate direction, but under the direction of a doctor. So the doctor isn't there 24 hours, but the doctor does come in periodically, and the doctor does assess the patient. Like, they are, so I think there is so often that they actually have to lay their eyes on every patient in order to continue to get paid. A lot of the times the nurses, we relate to like, if we say there's something going on with this patient, that's something acute or something new, the doctor will go see them and prescribe things, or not prescribe them, depending on what they feel is best for whatever is going on. We also have CNAs in long-term care facilities, and what they do is they assist with the ADLs for their patients. So a patient who cannot turn or reposition to prevent them getting bed sores, we turn and reposition them. If a patient is incontinent of bowel and bladder, then CNA changes their briefs. A patient who's not able to bathe themselves, the CNA bathes them. Like, the CNA is there for all the activities of daily living. The nurses are there for the activities of daily living, as well as providing medication. That's what a lot of nurses, they fail to realize. You are there to attend the needs of activities of daily living as well. That is not beyond your scope of practice, but you are also there to provide medication to if you notice changes going on with the patient, acute, like any changes, acute changes, non-acute changes, any changes at all, to make the doctor aware, to relay critical labs to the doctor. If you get a critical lab call from the emergency room, say if something's critical critical is critical, you need to make the doctor aware. That's what the nurses are there. Some long-term care facilities, the nurses have to draw all the blood work. Some have phlebotomy that comes in and draw the lab work. That's essentially how it works in long-term care. Now, acute care. Acute care is your hospital. Everybody knows what a hospital is. There may be another level of acute care, but the acute care I'm speaking of is the hospital. A hospital runs like this, and there's different floors. Different floors have different ratios. So I know on a med-surg floor, it can go, post-COVID, child, I've heard of people having 1 to 9, which is ridiculous. During COVID, I've heard of people having like 1 to 10, one nurse to 10 patients. I myself, 1 to 6 is my limit, and that's my limit, and that's my limit because that's what I've worked with. I heard in California it's like 1 to 5 on med-surg. On med-surg floor, they're supposed to be not as acute as someone say on a trauma unit or on ICU. There might be someone who came in with a condition and then they need some treatment, but it's not on the level of needing ICU or PCU care. But what I have found is a lot of med-surg patients end up having to be transferred to other floors because their level of acuteness is higher than what they were presumed to be coming up from the ER, or their level of acuteness progressed as they were on the med-surg floor. But on, say, the hospital, how it works is you come in. Also, this is a nursing home too. I forgot to mention the morning huddles. A lot of nursing homes want you to do morning huddle. That's where the CNAs that's oncoming and the nurses that are oncoming, they do huddle with your oncoming. So the nurse has already gotten a report from the outgoing nurse, and then that nurse that's coming on, she does a huddle with her CNAs or his CNAs, just to let them know what's going to happen throughout the day. If anybody has any appointments, anybody's going to dialysis, anything that's going on throughout that day, letting them know, this is what's going on with these patients. Excuse me, these residents. They're called residents in long-term care. This is what's going on with these residents today, just so everybody can be on the same page. In the hospital, the oncoming nurse and the off-going charge nurses normally do a huddle where the off-going charge nurse runs down everything that's going on with the patients that are currently on the floor. At least in the hospital I work, that's how it was, the off-going charge nurse, because they've been with the patients the whole shift, so they know exactly what's going on with these patients. The oncoming charge nurse, she may not know what's going on. She hasn't been there. She just got there like 10 minutes ago or whatever. You know what I'm saying? So the off-going charge nurse will give report to the oncoming charge the oncoming nurses and the outgoing nurses. So the oncoming and outgoing nurses will be in huddle and report in the morning, doing shift to shift report. And it's just, with that, it's just really basically saying we have this many people, we have these rooms in restraints, we have these rooms who are hospice, we have these rooms, like, they're not giving you thorough reports on every patient, but they're saying like rooms 14, 10, and 20 are have restraints. Room this, and that, you know, room this is a hospice patient. This room is DNR. Like, they're very broad. But when you do report, which most hospitals prefer bedside report, when you do bedside report with the outgoing, you're the oncoming nurse and you're doing it with the outgoing nurse, you're going room to room. And you're actually looking, because you should look over your patients to make sure if there's anything given to you in report, it matches up with what we see on this patient. If they telling me that they have the nasogastric tube in the right nair, we're going to make sure it's in the right nair, not the left nair. You know what I'm saying? Because when you go to chart, you can't just go off what that nurse said. That nurse might tell you that nasogastric tube is in the left nair, but it's in the right nair. She might tell you we got a number 20 in the right arm, but the number 18 is in the left arm. You know what I'm saying? So you know what I'm saying? So you just have to look at the patients as you're getting report. You have lab that comes through and draws your blood. Unless, now in my hospital, if the person had a central line, a PIC line, midline, any type of central line, we nurses had to do their lab draws. Even if these phlebotomists could come and do a quick draw on them, it wasn't necessary, because you could draw it straight from that central line. So all the blood draws that were for central lines, the nurses had to do it. Outside of that, the phlebotomists came in and they did the blood draws. The RT came in and they did the neb treatments. In the long-term care facility, the nurses do the nebulizer treatments, but RT came through and they did no nebulizer treatments. These are in the hospitals that I worked in. Now, if there's a hospital in a smaller rural area, and you know, maybe they don't have all that, but this is what they had in the hospitals I worked in. Of course, things run differently in labor and delivery. I can't speak on labor and delivery because I never worked there. They may have one nurse to 3 patients. I don't know. I don't know how it works in labor and delivery. All I've ever worked is med surg. I've been on the PCU floor as just I was a med surg nurse, but you know, during COVID times, it is what it is. I was placed on a PCU floor, but I was so unfamiliar with some of those drips. I knew the drips exist, but I wasn't trained on how to titrate drips and, you know, do all that. I wasn't trained. I was trained on how to titrate like heparin drips, because those work off of a scale. And we were taught how to do that. But certain other types of drips like cardizem and stuff like that, we didn't have those. Those were considered heart drips. Cardiac medication drips. We weren't taught how to do those in med surg. So I was never assigned a patient who had that type of drip, who had the digoxin drip, stuff like that. I didn't work with. But from what I'm told, in the PCU unit, those nurses only got 4 patients. 4 was the max for a PCU unit, because their level of acuteness was higher than on a med surg unit. And then, you know, ICU, I've always been told it's been 1 to 2. I heard during COVID times, though, it has gotten up to 1 to 3, which was a lot, because in ICU you could have like 6 different drips, IV drips, or IV lines, or IV antibiotics. Like, you could have 6 different drip IV medications going. You know what I'm saying? That's a lot to keep up with. So it was like 1 to 2, and then you had to constantly flip the like you had to chart and chart on them like every 15 minutes. You had to assess them and chart on them like every 15 minutes, which is a lot, you know. For like a med surg, we charted on our patient. I believe we had to actually physically do 1 assessment per shift, and then chart on them every 4 hours, I believe. We had to do 1 full assessment per shift unless something happened and required more. And we had to chart on restraints every 2 hours. We had to actually look at the restraints, do the assessment that's needed, and chart on it every 2 hours. And then we had to actually chart on them, I believe, every 4 hours during the shift. And the 12-hour shift, we had to chart on them every 4 hours, I believe, if I can remember correctly. But you got 6 patients, and was it every 8? I can't remember, y'all. I think it was every 4 hours we had to chart on them on a 12-hour shift. But restraints had to be assessed and charted on every 2 hours. But with 6 patients, you know, if your patients shouldn't, that's why I said a certain level of acuity. You got 6 patients and you're doing this charting. It may not seem like a lot, but actually getting to it to do it is a lot, especially when you're short on PCT. So then you're having to actually do total care for, say you got 6 patients, the PCT may only have to do every other patient. So your other 3 patients, you're responsible for all aspects of their care. So it was a little more difficult for me in the hospital. It was more work, honestly, with 6 patients. A lot of people think you got 6 patients in the hospital and you got 30 in long-term care, but those 6 can feel like 30, trust me. If they have a Foley, you have to chart on the Foley every so often. In long-term care, we just have to basically chart that Foley care. You do Foley care and you chart that the Foley is, you know, in the right position and, you know, stuff like that. But in long-term care, you have to actually chart on the Foley every so often. We do these things called, what are those checks called? Y'all, I'm drawing a blank, but if y'all know what I'm talking about, certain things were considered high risk of infection, like having a central line, having a Foley, and oh goodness, what was the other thing? A central line and a Foley. We had to do at least 2 of them a shift. And where we had to go through and assess, like with the central line, we had to assess that, you know, that it was patent, that the dressing on it was not out of date. I forgot the other things we had to assess with the central lines. On the Foleys, we had to assess that they were below the bladder, but they were not on the floor, that they had a leg strap on them. Just different little things we had to do on the K cards, but you had to also chart on those things. You had to actually chart on those things specifically, as well as, like I said, charting on the restraints specifically. So it was a lot. It was a lot. Then you had to do blood transfusions. If someone came back with a hemoglobin under 7.0 in my hospital, that person more than likely ended up getting a blood transfusion. So you had to, you know, do that, match, send that request down for the blood, and the blood would come back up through the tube, and then you had to get a second nurse. You had to verify second checks with everything, make sure this is the right blood, right patient, and you had to initiate. Like, there are different things that can happen throughout your shift in the hospital, that say if these things were to occur in the hospital, some of them in it were to occur in the long-term care, we're going to send the patient out because this level of acuity is too much for us. But if it occurs in the hospital, you have to take care of it right then. Is that we had sepsis protocol. We had to chart if certain things ding on this patient, like if 3 out of 5 things this patient had was exhibiting, then we had to put them on sepsis protocol. Like, it's just so many different things in the hospital. You have to be constantly assessing. Now I'm thinking about, I'm like, how did I even get through the shifts, y'all? You have to be looking for orders constantly, because the doctor can go in and change orders. Say you might have normal saline hanging on this patient, or D5.5, and then the patient changes it to LR, or, you know, anything can happen. You got to be on top of that. You got to be on top of when labs are being drawn. You got to be on top of looking for those results, because the doctors are not going to be going in just looking at everybody's results like that. You got to be the eyes and ears. So if you know a patient just got their lab drawn 30 minutes ago, within 45 minutes, start looking for the results, because it might be something in those results. So you got to notify the doctor, hey, the potassium level is this. Now, where I work, they had certain protocols that we didn't have to automatically call the doctor, because if we looked at the lab level and the potassium was this level, then we initiated this protocol. You know, we didn't even have to call the doctor. It was a set protocol already in the computer. So we were well within our rights to, if the potassium was this level, we initiated this protocol. If the calcium was this level, we initiated this protocol. If the magnesium was this level, we initiate. You know what I'm saying? They had preset things in the computer for that, but you had to be aware. You had to look at the results. What else can I say? Now, what I will say is, in the hospital, although we do tend to cater to the family, we are primarily catering to the patient. In long-term care, it seems like you have to cater to the family as well as the patient, and sometimes more so the family than the patient. But in the hospital, we tend to cater more to the patient than the family. And sometimes the family can just be just all sorts of ways. They could work against you. I've said it in some videos before, like you got this patient who just came down from ICU. They were on a insulin drip because their blood sugar was like 900. But then they come down to your floor because we've gotten them stable, they've gotten stabilized, their blood sugars are running, I say around anywhere from, could be on a scale from like 150 to 3 something, but we have regular Acute insulin we can give them. But then you have their family members who's bringing them Bojangles or KFC, or you know what I'm saying. So sometimes you have the family working against you. This is what I've observed. You have the family working against you. You know what I'm saying? They're just doing what they're used to, but you shouldn't do what you're used to because your daddy or your mama or your cousin or your auntie or whoever was found on the floor unresponsive because they had a blood sugar of 900. You know what I'm saying? But one of the nurses, we had to carry phones with us all throughout the shift, because if somebody need to get in contact with you, they don't want to be running from room to room trying to find you. You could be on your break and that phone will ring. You know what I'm saying? It'll be the people telling you the monitors in room such and such calling. You could be on your break and you'll get a call. Such and such is off the monitor. Tele number is off the monitor. You know what I'm saying? It's just, it can be aggravating, y'all. And let me not get into night versus day, because I tried to be that nurse that used to be like, okay, night shift was much easier. Night shift more downtime. Night shift was this. I ran so much at night. It's like in the hospital, it ain't so much of it's a downtime at nighttime, because nighttime will run you just as much as daytime in the hospital, and I know because I work both of them. And I actually, when I was working nights, I used to get sometimes frustrated that things weren't done by the day shift nurses. I ain't gonna lie, I used to get kind of frustrated because I used to be like, they had, why you didn't do it, thinking, because you can go in the system and you can push the timing of people's medications back. So if a day shift, if a med is time for 5 p.m., say a med is time for 6 p.m., and the day shift nurse isn't able to get to it, she can push that med back to like 7:30. You know what I'm saying? And then you could tell that the med was pushed back when you get it. And so I used to be like, why they put this on, But once I went to day shift, I was like, oh yeah, I see why. Because you barely got time to, when they say you barely have time to take a lunch, yeah, they're not lying. Day shift, it was worse on day shift than it was on night shift. And I thought my problem with night shift was me being sleepy, and let me go on day shift. And child, I work harder on day shift than night shift. So anybody who tell you that day shift, let me tell you, if they tell you day shift is easier, there really is. I say I work harder on the day shift, and I feel like I did because the doctors were there. They were there, and they were changing orders just all throughout the day, and you feel like you finished. You finished that patient for that time frame, but then you go look and the doctor just put a new order in, and you're like, oh my goodness. So now you got to go back. Oh, and that's another thing. In long-term care, they have medication carts where they push the carts down the hall, or they don't have to push the carts. You can walk back and forth. It's up to you, where they keep medication on. But in the hospital, everybody's medicine is in a centralized system we call a Pyxis. So the Pyxis might have Norvasc in it. They have all kind of medication basically, but they have several doses of the same medication. Anyway, I hope this kind of explained the difference between long-term care versus acute care. If y'all have any questions, if y'all feel like I said anything wrong, if you have anything to add, just put it all down below and I will respond to you in the comments. I'm gonna show y'all how my hair looks after my niece is finished braiding it, and I'm gonna show y'all how if I go to my class reunion, it's today, my 30th class reunion. I was gonna go get my nails and stuff done, y'all. I thought the class reunion was at 7 p.m. y'all. It's at 4 p.m. It's already 11 o'clock. That's like 4 hours. Yeah, I'm probably not gonna be able to go get my nails done, because I don't have to get there at 4 o'clock. I can roll through at 5 or 6, but if I get my nails done, I want to get my pedi too, because I want to change my nails to like clear, almost like an opaque color. And then I'll have to do my toes too, and I know I won't have time to do both. I wanted to show y'all my hair. Guys, I changed my mind about going to the class reunion after I finished getting my hair braided, and I was just so tired, y'all. So hopefully, I'm hoping they do something in the morning, like a brunch or something. I'll go to that, because I wasn't able to make it. But I wanted to show y'all my hair. As I told y'all before, it's braids all summer for me. Might be braids all winter too. I did dye my hair, but I missed that little gray patch right there, so that's there. But y'all see this? My niece did a good job, y'all. And I ordered my quality next week. The quality of my video should be much better, because I finally ordered a better grade phone. Still not a camera, phone. See y'all on the next one.